In this study, we looked at how the prevalence of substance use in young people coincides with the endorsement of co-occurring other mental health symptoms like symptoms of depression, anxiety, symptoms of ADHD, including hyperactivity, psychotic experiences, and suicidal thoughts and behaviors. And what we found was really striking. We see that as substance use increases in frequency, so as young people, this was a high school sample, so as high school students endorse more frequent substance use, their endorsement of other psychiatric symptoms so too also increased. And what was pretty remarkable is that we see really, I think, two things. One is that we see that this increased risk for psychiatric symptoms emerges at even low levels of substance use. So this isn't just among, it's particularly prominent, of course, among adolescents who are engaging in daily and near daily substance use, but we see it even in the transition from ever use to just past 30-day use. We also see that the pattern of findings looks remarkably similar regardless of whether we were addressing cannabis, alcohol, or nicotine. So all of this effort really on kind of triangulating patterns that are specific to cannabis or patterns specific to nicotine or specific to alcohol, we really don't see. We see that the pattern really does look the same regardless of what the student reports choosing. To me, the biggest takeaway is very clear. I do a lot of trainings with schools in Massachusetts, and the main thing that I really try to impress upon the schools that I work with that we see in these findings here, which is this idea that for many, many young people who are engaging in substance use is often the smoke, but not the fire itself. And so what we see in these findings here is that for a lot of kids who are using substances, they are also struggling with a lot of other psychiatric symptoms that are causing pain, and that might serve to not only be risk factors to initiate use, but might also reinforce continued use and progression. I think that the main thing that we need to see from these data is that comorbidity is common, and that kids who are using substances are often really struggling and really hurting. And our treatment efforts, our prevention efforts, and our policy efforts really need to embrace the whole student. So when we say dose relationships, what we mean is that the relationship between substance use increases, like as substance use frequency increases, the severity of psychiatric symptoms increase, right? So we see that there is a significant difference between kids who, in terms of prevalence of psychiatric symptoms, among those who've never used any of these substances and those who've ever used any of these substances. But also as students use more frequently, the endorsement of psychiatric symptoms also increases. A lot. So there's a lot out there on, really highlighting that kids who, for example, kids who have co-occurring use cannabis and have co-occurring ADHD, that kids who have ADHD are far more likely to both use cannabis and far more likely to have difficulty quitting, have more severe trajectories of use. So yeah, so there's a long line of research really highlighting comorbidity between substance use and other psychiatric symptoms. So for example, kids, we know that ADHD is a risk factor for both initiation of cannabis use as well as progression of cannabis use. We know that kids with ADHD have more difficulty quitting than those without. So those relationships have long been established. There isn't as much work comparing the profiles of psychiatric symptoms by substance. So we've tended to look at within silos of substance use. So looking at how risk factors among kids who use cannabis or kids who use nicotine or kids who use alcohol. And I think one of the things that is rather striking in these findings is that that pattern really does look pretty similar across the three substances most commonly used in this age group. We're humble about these findings. These are cross-sectional findings, so it's point in time. So we certainly can't suggest from here whether one causes the other. So the next thing that really is needed here is to look at this longitudinally, to look at whether these other psychiatric symptoms are risk factors. Do they exist before substance use even comes on board? Are they risk factors for using substances, or do they emerge as a consequence of using substances, or do they simply exist in parallel? So we'll need to be following these types of cohorts over long periods of time. Fortunately, one of the data sets, the first data set that we highlight in this study here, is a longitudinal data set. So we will be able to look at how progression in substance use may coincide with progression of psychiatric symptoms and vice versa, to try to understand and unpack ordering here. We also need to understand how to better support kids from an integrated framework. So what are the best both universal prevention approaches, targeted prevention approaches, so for kids who are at risk for both substance use and psychiatric comorbidities, as well as treatment approaches. As I mentioned, I do a lot of work with schools, and much of the substance use intervention work in schools is focused squarely on the behavior of substance use, rather than really understanding how these psychiatric symptoms interface with substance use. So we have a lot of work to be done to improve our intervention efforts that really do embrace the whole child, rather than addressing just this one behavior or this one symptom in isolation. I go back to this saying, which my team I think is sick of hearing me say, which is that substance use is often the smoke and not the fire. And I think it's really important. Substance use has historically been highly stigmatized, has been chalked up as a quote unquote moral failing, or as purely a behavioral issue. And I think it is really important for us to now, especially in the midst of this ongoing youth mental health crisis that we are in right now, to understand that substance use for many people is a manifestation of, and that we need to be working with our clients and with our patients to understand what are those other mental health factors that might be reinforcing use, and providing support for those factors of symptoms at the same time. I really do believe that if we are going right at substance use alone without addressing their anxiety, their depression, trauma, symptoms of ADHD, thoughts of suicide, whatever it might be for that particular student, we're really not going to get anywhere. And I think these data really do highlight that comorbidity is quite prevalent and quite common in kids with frequent substance use. I oversee the SURF study, which was the main survey presented in this paper, and it was a massive screening effort. And so really making sure that we were collecting high quality data. So there was a lot of work that was done with every single school that participated in this study to make sure that we had solid data collection procedures in place, and that we were regularly looking at the data, processing the data, so that we were troubleshooting as we were going along. There is, doing, community-based research, which is what I do. There's a lot of work in, working with the communities themselves to make them aware of what we're doing. So we did, a lot of work with, presenting to the schools and presenting to parents and caregivers ahead of time, so that they knew what was coming down the pike, and being able to field questions from every parent that had questions before the survey went live. So just a lot of logistics, but by and large, everything was, pretty smooth. And our school partners are just exceptional partners in this effort. Many of them have been with us for a long time, and we're really grateful for their partnerships in this work. It really would not have been possible without their participation. Yeah, so we have a number of different projects that are active, or hopefully will be active soon. In my group, some of the work that is ongoing right now is we are working with many of the schools that were participants or sites in this survey work, and actually testing different intervention approaches, as I mentioned earlier. So we have a project where we are, it's funded by the Department of Public Health in Massachusetts, where we've developed a curriculum called I Decide, which stands for Drug Education Curriculum, Intervention, Diversion, and Empowerment. And it's a youth diversion program. So it's a program that aims to provide schools with more restorative and supportive alternatives to punishment for school-based substance use infractions. So we developed this curriculum that not only provides psychoeducation around substance use, but also addresses many of these mental health comorbidities that are going alongside substance use, and really trying to work with schools to take a more restorative stance around substance use. So that program is being implemented in well over 300 schools, middle schools and high schools now across Massachusetts, and we are training facilitators as well as also evaluating the outcomes associated with that project. We also have a program that's funded by PCORI as well as the Department of Public Health here in Massachusetts, where we are trying to figure out ways to optimize universal screening for substance use and evaluating kind of novel techniques of doing that, one of which is deploying youth wellness coaches, which are individuals near peers with lived or living mental health experience to better support mandated and non-mandated universal screening efforts for substance use. I think, again, just kind of going back to, what I think is the main punchline here, which is that kids who are using substances have not committed a moral failing, right? Many of them are struggling with real symptoms of distress, and it is our responsibility. I'm a psychologist, I'm a clinician as well. It's our responsibility to really be seeing the whole child and not punishing away a behavior, but really appreciating the symptoms that are reinforcing use and working to support both the student, their families, as well as the systems in which they're involved to help them heal.
Thank you so much for having this interview with me. That's all the questions I have.
Of course.
Have a good rest of your day.
Thank you. You too. Take care.
Bye.
Bye.